Okay. Hello, everyone. Thank you for the opportunity to present this case. I hope it's a good case and you find it interesting. It's a case of a gunshot wound to the groin. Let's see if I can advance my slides. The activation that came over the pager was a 20-year-old male with a gunshot wound. It was reported to be in the left lower extremity. Injury reported was an expanding hematoma on the left groin. He was hypotensive in the field, blood pressure 70/40s, tachycardic in the 150s, on room air setting 100%. EMS was able to apply pressure to the left groin, and we triaged him straight to the operating room, the ED/OR. We have a operating room right next to the trauma bay. Upon arrival, he was obtunded. He was intubated immediately. We confirmed bilateral breath sounds and end-tidal CO2. On C, he had an expanding hematoma in the left groin. He had no pulses in the left lower extremity. He was remained hypotensive. He had 2 large bore peripheral IVs that were placed in the upper extremity. Whole blood was started with 2 units. MTP was activated. And on exposure, he had what appeared to be 2 gunshot wounds, one in the left groin anterior, you can see in the diagram, really close to the area of the inguinal crease, and then another aperture posteriorly on the left side. We did a chest x-ray that showed the ET tube was in good position, and we did a pelvic x-ray as well. You note he has a cordis that was placed in the right groin, which we held off on using. We were using the upper extremities for infusion, but the groin line went in. The arrow on the left side, on the right side of the screen, kind of points to some shrapnel on the left side over the iliac bone, and maybe some shrapnel here too, but not quite sure. And of course, there was blood all over his belly. So how would you like to proceed at this time with this patient based on what you suspect he has in terms of vascular injury? And then with that in mind, how would you go about proximal and distal control for this fellow?
Thank you, Doctor. Dr. Frisby, your comments?
Wow. Yeah. Can you hear me?
Yes.
Probably. At this point, he's near the crease, left groin crease.
Yes, sir.
He's blasted out his iliac. So I would probably try to get as close to his. I would try to get proximal control with opening his belly and cross clamping his aorta. At that point, about distal control, you might have to open the leg and get distal control at that point. But that's the only thing I can think of at this point, because it looks to me like if he's very close to the crease, he may have caught the external iliac down to the leg, but it's more likely he's taken them both out. Whoever shot him but that's all I have.
Thank you, Doctor. Dr. Kasim, your comments?
So it looks like this is a non-compressible injury. I don't see any bullets lying in the pelvic cavity. So where are the bullets? That's the next question I want to know. So the most expeditious way of getting control of the vascular injury is a direct control of the blood vessel in this area, because more than not, it is not compressible, and you shouldn't be wasting time. So, like Dr. Frisby says, either you open the abdomen and you either cross clamp the aorta or you cross clamp the iliac on the injured side, and then you look around to see what other injury he has sustained, and I don't think it will be an isolated vascular injury I'm pretty sure there are other things going on to this belly as well. At least you will get control. Also, or you have to do a groin incision to get control of the either common femoral or the SFA as well as the profunda. So I'll stop there for the time being.
Thank you, Dr. Kasim. Dr. Antrak, your comments?
Yes. So first of all, the wound looks like it may have been in and out. So the two wounds, really one gunshot in anteriorly out through the buttock or vice versa. But this is an easy one. I think you're the one that talked about Black Hawk Down injury, and there's a classical one for use of the Reboa in zone 3. And, the fact that you say the hematoma is expanding despite holding pressure, in that case, I would opt for that on the right side, the right common femoral, get control, and then proceed to the operating room. In the operating room, I would, you can make a groin incision and then extend it upwards and transect the inguinal ligament, but you don't have to do that. I think you're the one that mentioned the renal transplant incision. So once you get control with the Reboa in the operating room, you make a curvilinear incision, cephalad to the groin, and stay in the retroperitoneum and dissect out the external iliac artery for definitive control there, and then an incision in the thigh to dissect out the common femoral artery, and then you can tunnel between the two incisions and really see the area of injury. And once you get control of the common, the external iliac, you can deflate the Reboa to get control of the common femoral artery or the SFA and profunda, and then look at the repair. Also, you may have injuries to the veins, and you would get control of the corresponding veins through the same incisions.
Thank you, Dr. Antrak. Dr. Ochman, your comments?
My apologies, I was having some problem with the microphone. No, I was going to suggest exactly what Dr. Untrak suggested. An incision above is, I call it hockey stick, a few centimeters above the inguinal ligament. When you get near the iliac crest, go up and do a retroperitoneal dissection there to get proximal control of the iliac vessels. And that usually the bleeding kind of diminishes significantly there, doesn't stop completely, but significantly. And after that, distal to the injury, get distal control. This patient, I agree with Dr. Untrak, this appeared to be an exit and an entrance. So he might have, it's less likely, more things are more common, so most likely are the femoral vessels that appear to be blown. But he could have a posterior injury. He could have an injury to the one of the gluteal arteries, and that also might be bleeding based on the trajectory. But I would start that way, proximal and distal control, and see what happens.
Thank you, Dr. Hochman. Dr. Burke, would you like to make any comment?
Yeah. So, Dr. N, were you thinking that this was an entrance and exit wound? Is that what your thoughts were in examining the patient?
I mean, certainly it could have been possible. There was that shrapnel that we saw on the plane film up, so that was also something that could not have been ignored. And then we weren't sure if there was any shrapnel on the right side, as bullets can hit bone and then they can travel anywhere really. But we thought it could be through and through, but we could not ignore the shrapnel particles that we saw as well.
Yeah. Did you do a fast exam or abdominal X-ray?
The fast was negative.
All right. So I was just checking. I mean, obviously, and then in terms of the wound itself, I assume you have someone holding pressure on the femoral vessel at the inguinal ligament. Did you get any sense as to whether there was like a major artery or just major vein or both, or could you tell?
It was arterial. There was definitely arterial.
Big
and
pumper.
the tourniquet, we could not put a tourniquet in that area.
Yeah, for sure. I totally agree with Dr. Untrack and Dr. Hoffman. I would do I'd do a hockey stick and extend it down into the down as close as I could to the wound, and expose the vessels that way retroperitoneally.
Thank you. And Dr. Colette, would you like to make any comment? We cannot see your video, but. Dr. Colette?
Yes. Oi, alô?
Yes, we can hear you, but you get somehow muted, doctor. Okay, so we can go back to you, Dr. Nedelcoviciu. It looks like Dr. Colette is having some trouble.
Okay, so thanks everyone for all the comments. Definitely, options would have been, a rebound on the right and then cut down versus hockey stick incision going to retroperitoneum. The concern with the hockey stick was that given the shrapnel, we would not be able to investigate the peritoneal cavity. So what happened was basically we started with an exploratory laparotomy. The backup surgeon came as well, and also vascular surgery was called as well. Exploratory laparotomy, there was no intra-abdominal injuries and no pelvic hematoma, but holding pressure from the inside with the fist as cut down on the left groin was performed. And it was found that the left common femoral artery was taken out by the bullet at the junction, at the bifurcation between SFA and profunda. And then the common femoral vein was taken out basically at the area where the great saphenous vein drained into the deep and just superficial femoral vein. And you can see here on the screen, so this vascular clamp is placed on the common femoral. The bulldog here is on the profunda. There is another angle clamp here on the SFA, proximal SFA. Then moving up here, bulldog on the vein, another right angle clamp on the distal junction between the deep and superficial femoral vein. And then this bulldog here is sitting on the great saphenous vein. And I couldn't find any other diagrams to kind of show where the injuries, but this was basically taken out with the common femoral artery hanging out in the breeze, and then proximal SFA really disconnected from the common femoral as well as the profunda, with venous bleeding coming from this area. What's missing in the diagram is the greater saphenous vein, but this was taken out as well. So we are now ongoing resuscitation. His lactic acid is 8. He got 9 units of blood, 9 of FFP, 2 units of the whole blood, cryoplatelets, tranexamic acid, crystalloid. We used the green Fogarty balloon to just embolectomize the SFA, which looked kind of small in diameter, but anyways, we got out all that clot. And now kind of moving forward with his care, what I would like to see are the group's thoughts with regards to, shunting, repair, when are we going to repair, and what are we going to repair? If you ligate, what would you ligate now in this situation with this sick patient? And with regards to fasciotomy, would you do calf or thigh or both?
Okay, thank you, Dr. Hoffman. Your comments? We cannot hear you, Dr. Hoffman. Not sure why.
Sorry, now okay. Yeah, I'm having some problems with my microphone today. I'm sorry. The first thing I will do with this patient, the moment I get proximal and distal control, is to give 5,000 units of heparin, because you cannot keep working unless the patient is fully anticoagulated. And still you have to pass the Fogarty, like like this, but that's important.
We
This patient is
gave 7,000. Sorry, we gave 7,000.
So yeah, you may get these things too, even with the heparin. So the other thing is probably the vein, most likely than not, in a patient like this with severely acidotic, probably I would ligate, and I would just probably repair the artery. In theory, we need to repair the vein before the artery, but this probably cannot be done. It's a big segment missing, even repairs of this segment. We have a case recently here that we did an interposition graft with grape PTFE, and they thrombose eventually. So I wouldn't waste my time in a patient like this trying to repair the vein. The artery, probably we do an interposition graft with PTFE. Normally we prep the other side, we get ready to take vein from the other side. However, the study has not shown a difference between, we tend to think that the vein is better because it's a contaminated tissue, but the vein essentially is avascular because when we resect the vein, the vasa vasorum of the vein are transected. So it's an avascular segment, the same way that the PTFE is a vascular segment. So the studies appear to be equivalent. We use PTFE frequently. I don't think it has more risk of infection, and you need to get out of there ASAP with this guy. And this guy, I'm sorry? Sorry, Dr. Collet, you were saying something? Well, I don't know. So, and you had to reimplant both the profunda and the superficial femoral. So this is a complex case, and you need to do it quickly. And after that, yes, fasciotomies, both thigh and calf. Thank you.
Thank you.
Thank you, Dr. Rahman. Dr. Kasim, your comments?
I would do it slightly different. And now you have the vascular clamp of the femorals, and then you have vein. You need to dissect out the SFA from the opposite leg. And before, hopefully you'll have another team doing that. And in the meantime, I would shunt the SFA, put an argyle shunt in there while you're doing, getting ready. I would go ahead and slice the SFA, the long saphenous vein from the opposite side and use it as an interposition graft to repair the vein. I'm not thrilled to ligate the vein in a case like this. And if I've done that expeditiously, and if I have the luxury of time, I would go ahead and put an interposition graft using the vein again on the arterial side. Now, if I've used up a lot of my time, and also knowing that you have had a lot of blood product you have given to this patient, and I still have time, I still have work to do, i.e. fasciotomy, I might just leave the argyle shunt in the arterial side, and he's been well anticoagulated with 7,000 units of heparin, like doctor says, and leave the shunt in place, do my fasciotomy, and then bring him back to do definitive repair of the artery 24 to 48 hours later. After I have warmed him up and got him hemodynamically stable and reversed all the acidosis and all that. I will not forget to do a complete fasciotomy, because that's what's going to get this guy later on. So it'll be a staged procedure in my hands, and I would be cognizant of the fact that I'm spending a lot of time in the operating room, and he's got a lot of blood product on board, And I would like to get him to the ICU as quickly as possible to warm him up. Thank you.
Thank you, Dr. Kasim. Dr. Burke, your comments?
Yeah. How long from the gunshot wound are you right now in the OR with control of the vessels, like in that picture? Is it a couple of hours?
So he arrived fairly quickly, and for 3 hours going on to 4 hours.
All right, 3 to 4 is a long time. And how cold is he, and what are his vitals?
So he was cold. He was hypothermic, and his blood pressure came up. Once we stopped the bleeding, he was normotensive, but he was cold, and his lactic acid was 8.
Well, I think I would try and do what Dr. Hoffman said with PTFE and reimplanting the SFA and the profunda. I'd probably ligate the vein and do fasciotomies.
Thank you, Dr. Burke. Dr. Antrak, your comments?
Yeah, so, the issue is whether, it must have been 30 minutes or so to get the exposure in the operating room. And if he's hypothermic and acidotic, then the ligating the venous system and then putting PTFE to the profunda and SFA, that'll take an hour to 90 minutes minimum. So I think that probably would extend the operation too long. So in this case, I would consider putting a shunt Argyle shunt into the SFA. I think temporarily you can ligate just oversew the profunda, the origin, and then consider even putting an Argyle shunt in the venous system, doing a fasciotomy. And I think in this case, you just need to do fasciotomy below the knee. Very rarely do you need, I'm not sure about the thigh, but if there's any doubt, I would go ahead and do it, but certainly below the knee. And then let the patient warm up and let his lactic acid normalize, come back down to normal. Then in the second trip, the PTFE is fine to both the profunda and SFA, and then you'd have more time in a leisurely fashion to consider what to do for the common femoral vein.
Perfect. Thank you, Doctor. Dr. Frisby, your comments?
Yeah, I think I agree with Umtrek. I don't have any problem with the shunting of the arteries. That vein bothers me. That's a lot of blood coming back. And also he's cold and he's acidotic. So I would shunt him and temporarily tie off the vein, get him back to the ICU, warm him up, and try it again. This time, see if you can do something about that vein. The vein is the thing that's going to be the limiting issue here, because anybody, we can always, the vascular surgeons can always do something about the arteries. The vein is going to be the limiting factor. So those are my only comments about it.
Thank you, doctor. Let me try one more time with Dr. Colette. Dr. Colette, can you hear us? No. All right, so we go back to you, Dr. Nedelcoviciu.
Thank you for all the comments. So yeah, I was definitely getting into close to like the fact that he had a lot of clot in the SFA. We definitely worried about reperfusion, even though timeline, okay, 3 hours, you're getting into 4. So just before what we actually did, basically, just want to put this out here from 2015 plenary paper AAST with regards to just the use of temporary intravascular shunts in trauma. And basically, the objective was to evaluate the use of vascular shunts in trauma and, as a viable treatment option. They looked at 213 injuries. There were 7,385 patients, high ISS, 26% had ISS greater than 25, and 71% had penetrating injury mechanism. Majority were gunshot wounds, and shunts were placed for damage control in more than half, 63.4%. And also for stage repair, where ortho injuries were associated as well. And only less than 1% of the cases, shunts were placed just because there was no availability of a vascular surgeon or surgeon skill set. Most commonly, the shunts are used for the injury to SFA, which looks like we had in our case. Popliteal artery then comes next with 18.8%, and then brachial artery 13.2%. Argyle shunt is the shunt that was seen to be most likely used 81% of the time, and Pruitt in Ahara 9.4%. And dwell times really varies, but basically, according to this study, just only 4% had the shunt in place for more than 48 hours. And issues from the shunt really were thrombosis and dislodgement. It just resulted in a pretty good salvage limb rate of 96.3%. And they concluded that obviously shunting can be considered, and it's a definite viable option. And this is what we did when we took the patient back to the operating room. It's just that over there, we did not have the Argyle. We had this Sun shunt, and it was like, okay, I've never used this, more familiar with the Argyle shunt. But anyways, with the vascular team, so basically, this shunt, one was placed in the common femoral to the SFA, and the profunda was ligated temporarily. And then we shunted the vein too, and performed the left thigh 2-compartment fasciotomy via lateral incision, and the calf 4-compartment fasciotomy, 2 incision, 1 medial, one lateral. We can see here the common femoral with the shunt going down into the SFA, and then same on the venous side. As I said, I'm not very familiar with this shunt, but basically it just comes in 2 forms. Is used for carotid artery, and it's an internal shunt, whereas this other one is named external shunt because it has this external loop. And then they are divided even more into another category if they have or not this 1 centimeter non-reinforced segment. You can see the difference in diameter. This would go in the distal vessel, and this in the proximal part of the vessel. The table looks a little busy, but honestly, they're just like small, medium, or large, and there are more more categories just because of the internal, external, and the non-reinforced segment. The thigh fasciotomy, just quickly, there are 3 compartments in the thigh. Personally, I have more calf fasciotomy under my belt than thigh fasciotomy, but the ones I've done really decompress the anterior and the posterior compartment via lateral incision, either going through the fascia here and then kind of through the muscle with the retractor to find the posterior fascia, or a flap underneath the skin here, and then decompress the posterior compartment. I'm curious to see if the group releases the medial compartment, but usually we found that it's not necessary. So now the patient is post-operative day 1. He is now off pressors. He has Doppler signals, tibialis, posterior, and dorsalis pedis. He is rewarmed. His lactic acid is 1.2. He's doing well on a heparin drip. And the questions now are, how long keep the shunt in place, and how do you plan the vascular reconstruction in this situation? Keeping in mind that he's a young guy, 19, 20 years old. Valeria, thank you.
Thank you, Doctor. Dr. Antrak, your comments?
Yeah. So, well, he can go back any time and be up to the vascular surgeons, but the physiological insult has normalized, so you can take him back. You can't leave the shunt in indefinitely, but certainly 24 to 48 hours, but not much more than that. And So I would plan to go back the same day and, revascularize it again, up to the vascular surgeons, but it has to be a bifurcation graft to the SFA and profunda using either PTFE or vein from the other leg. But, you say he's a young guy, so maybe is it more important to preserve the vein on the other leg, or then consider the long-term complications of the graft? Which can be dealt with very easily if they occur, if you put PTFE in place. So, and then also I would attempt a reconstruction of the femoral vein on the right side also. I would urge the vascular, certainly discuss it with them, and if they agreed, fine. If they didn't agree, I would press them a little bit, but ultimately they would decide. But I would favor repairing both the arterial and venous system.
Thank you, Doctor. Dr. Kasim, your comments?
I beg to differ. I don't like this shunt, especially on the venous side. I prefer the Pruitt Inahara shunt because it's got a side arm and you can periodically infuse heparin into it, because the venous side, the flow is so slow, sometimes it thromboses. And I've seen that in my own practice. So therefore I use the Inahara shunt. Inahara was a surgeon in Portland, Oregon at St. Vincent Hospital. Nice man. So you've done a magnificent job so far, and you have a viable leg. Now the question is, when do you take him back? And like Dr. Untrak says, once you have warmed him up and your lactic acid is down to 1.2 now, and if he looks hemodynamically stable, 24 to 48 hours should be adequate. Having all these shunts looped up and exposed there, it becomes a little bit of tricky nursing care, and sometimes we have overzealous staff. Sometimes they pull them out, and be aware of that. And that I've seen once. I think I would repair both, and there is a very high incidence of thromboembolism coming from the venous side in cases like this, and also cardiac arrhythmias. I would be aware of that. So that's all I have.
Thank you, Dr. Kasim. Dr. Frisby, your comments?
Yeah, I appreciate all the comments. I wouldn't fall in love with that Argyle shunt. It's got to come out sooner rather than later. I think I would go ahead with PTFE. And despite everything's been said about trying to graft the jump graft of the vein, I think I'd probably have to try it, because that's a lot of blood coming out of that leg. So that's all I have. I would do the PTFE to the artery and to try to reconstruct that vein. That's all I've got.
Thank you, Doctor. Dr. Burke, your comments?
Yeah, I think that's awesome that you went the shunt route and it worked. I assume the vein is patent with the shunt in it. Yeah, I just have him back in the OR at this point and fix the artery and the vein. I'm sure the vascular guys can do both.
Thank you, Dr. Burke. Dr. Ochman, thank you for your patience.
No, I agree with Dr. Frisby. I'll do this as soon as I can. I have to say this was a brilliant idea to use these shunts. I don't have this, but they look very, the use appears to be very self-explanatory. And I will have ligated the vein, and maybe you can save the vein It has a high chance of thrombose, but as Dr. Frisby say, if you can save it, I will give it a try. And what you did, I think, is perfect. Trauma, we do things that nobody else does because we are in a very tough situation. So yes, many vascular surgeons might look at this and say, oh, why do you do this, whatever. One, because it's a trauma. You are trying to improvise in a very difficult situation in a patient who is dying in front of you. This is not an elective case. So I think this was brilliant the way you approached this, and I congratulate you. And this is the beauty of this conference. It opens your mind to new ways of doing things. So thank you.
Thank you, Dr. Rahman. Dr. Nedelcoviciu, we go back to you.
Yeah, thank you again for all the comments. So let me see if I can. So basically, so he was, as I said, young, small vessels. We spoke with vascular surgery and we wanted to see if there's a way to reconstruct this. Also, we tried to stay away if we can from synthetic, he's young. So what ended up being done as a repair. So for the venous repair, so his their saphenous vein was small, like 2.5 millimeters, like from, doing dialysis access, that in the upper extremity, a 2.5 millimeter is kind of like, you want 3 millimeters. So that's for upper extremity. To have 2.5 in the leg is really small. So this would have not been an adequate conduit to use for the vein. It was definitely a mismatch for the femoral in terms of diameter, and then also for the artery. So speak with the vascular surgery team. Basically, the technique used was a reconstruction of femoral vein using the spiral vein graft technique. Basically, because it was small, as I mentioned, over a 32 French chest tube, the greater saphenous vein from the ipsilateral leg was harvested, and it was already transected and injured from the area it was draining. So it was harvested, and then using 6-O-proline sutures, it was kind of rolled up over the 30 French chest tube, and at least it was probably more than 6 centimeter long venous conduit that we're able to obtain. And then the vein was repaired in an end-to-end fashion using 5-O-proline, proximal common femoral vein graft conduit, and then distal deepened superficial junction, really one channel. It was connected here. And then you can see here the shunt for the artery was still in place. You can see the aperture of the bullet hole and really how close this was to the crease. And that's why tourniquet didn't really work. For the artery, basically, the decision was to use a 7 millimeter cryo-preserved venous graft for the same reason. To use the saphenous vein from the other side, again, was small and different size, diameter. So we ended up using a 7 millimeter cryo-preserved venous graft end-to-end using 6-O-proline. The profunda, which was previously ligated, the sutures were removed. We had a back bleeding, and a bifurcation graft was used, in the sense that in the cryopreserved venous graft, the 3 millimeter graftotomy was performed to accommodate the profunda. However, because there was a little bit of tension and we didn't want it to kink the repair, kind of to bring it down like that, a small piece of the vein graft that was obtained with the spiral technique was actually used to bridge between the cryo vein to the SFA, to the deep, to the profunda, I'm sorry. And here with the blue arrow kind of shows where the lateral incision was for the fasciotomy. So that's how we repaired it. Just kind of looking a little bit about this spiral vein graft technique, I kind of, heard about it, but really the earliest thing I could find online is that has been published in 1974. There has been some experimental work done by Gluck in 1898 and Carrel and Guthrie in 1906, but you know, at the time when this paper came out, the synthetic grafts were considered for arterial repair, but there was really not much there for the for large caliber veins like the SVC. But it was kind of noted that peripheral veins can be sacrificed. They are long, and maybe this spiral method, which can be simple and versatile and unique, according to Chu, who put this paper together. And they did this study where basically they had 13 dogs, and they harvested the left internal jugular vein, and they sutured it in a running fashion using 7/0 silk over a glass rod. And they were able to kind of get the length and the diameter to match the SVC to replace for this study and experiment. And they were able to really obtain predictable diameter and length graft, really regardless of the degree of discrepancy between the size of the donor and the recipient vessel. And some of the failures they noted had to do with kinking or stenosis. Noted in the paper that there was no anticoagulation needed for this procedure, obviously not in this study with 13 dogs. But this is a specimen 6 weeks after the graft was placed, where according to the paper, they are describing the suture line is endothelialized and the surface is smooth with no thrombus or stenosis. Again, other areas of utilization, aside from the SVC, I've seen, just like on PubMed, kind of looking at some papers there, really, for aortic infected graft situations where you have an aortoduodenal fistula or a mycotic aneurysm, large thrombosed popliteal arteries from aneurysms. This has been used, the graded saphenous vein, for creating a conduit. Sometimes iliac vessels during pelvic accentrations or pelvic trauma can be repaired this way. The internal jugular vein had to be replaced. There was a case report. For renal transplant, if there are problems with the vessels, and maybe gonadal vein can be used as well. And portal vein can be reconstructed this way during Whipple procedures. And now we are basically between post-op day 2 and hospital day 10. The patient is extubated. He's on a regular diet. He's on heparin drip. His fasciotomy incisions were closed, so 72 hours after the last surgery. So we're kind of day 5 onto 6. He's ambulating with physical therapy. With transition, talking to vascular, he ended up being transitioned to Eliquis, and he was discharged on post-op day 10. And we thought, oh, this is great. But he comes back now, 7 days later. You can see here collection, but there's patent, artery, and the vein appears without clot. He presented with erythema to the thigh wounds and the fluid collection, as I point out on the CT scan. So he ended up going to the operating room with the team and vascular for washout, debridement. He was on 7 days of vancomycin. He grew Staph aureus, which was pan-sensitive, and he went back, and there was enough soft tissue coverage over what was done, so we didn't have to do any sartorius flaps or anything like that. And then he was discharged with the wound vac in place. So that's all I got. That's the case. Any thoughts? Any final comments?
Sure, doctor. Let's go to final comments. Dr. Antrak, any final comments?
Yes. Well, great case. Beautifully done. So now the spiral vein technique, that's totally new to me. So if I understand correctly, you take a narrow, long length of vein, and when you're finished, you have a shorter vein but larger caliber. Is that the point?
Correct.
Yeah.
Correct.
Yes. Okay.
This paper also had a way to kind of calculate based on the difference in diameter. But basically, let's say if you have you know, you need to replace a segment of like 4 centimeter length that has 3 times the diameter of the donor vein that you want to use for this technique. You do something like 3 times 4 is 12, so you need a 12 centimeter long, you know, vein like that, and then you just open it and do
Right.
it.
Okay. Okay, but when you
nice from the vascular team to you know, help us out with this.
when you cut the spiral in the veins, you no longer have a tube, you have a long strip, and then
yes, you have
a lot
long
of
strip.
so a lot of suturing. So somebody, and you suture over a chest tube or a stent or a shunt. So a lot of suturing. So how long does it take to actually, once you take a harvested piece of vein, and then you do the spiral technique and sew it until you're ready to actually do the anastomoses? How long does that take?
Approximately an hour.
Yeah. Wow. Okay. All right. But it's
The
elective.
shunts
here.
were in
Okay.
place and they were patent, so physiologically it was fine, so it was worth a try.
Yeah. Well, very, very well done. Beautiful case, and it's terrific. Okay.
Thank you, Dr. Antrak. Dr. Frisbee, Atlanta.
Yeah, I agree. I don't have any experience at all with the spiral technique, but boy, it worked here. It's a very, very good case. Lots of good points. Thanks very much.
Thank you, Dr. Frisbee. Dr. Kasim, final comments?
I've seen one case, Pancoast tumor of the right lung in the apex, encasing the supravena cava, and they use this technique to replace that supravena cava because patient had significant swelling of the face, and it was a palliative measure. Very nicely done. Very, very nice. I loved it. Unfortunately, you got a staph infection, but otherwise, beautifully done. Thank you.
Thank you.
Thank you, Dr. Kasim. Dr. Ochman, final comments?
Yes, I also don't have, my only experience on this is remembering that when I was chief resident that this was being discussed, but I don't remember having seen this done before. My only concern I would have about doing something like this, again, it's not done very frequently, and in a trauma situation, you need to be expeditious as possible. So is really any advantage over PTFE. It got infected, but you also have now a lot of suture material. You have a lot of proline around that vein. So I really not sure if don't get me wrong, this is perfect. You repair the vein and the artery, but I don't know how is this more advantageous than using just PTFE if it's infected. That's my own. I don't have the answer for that. Sorry, it's more a question than a comment. But this guy used safe both the vein and the artery, so I think this is brilliant. Perfect approach. Thank you.
Thank you, Doctor. Dr. Burke, final comments?
No, just that was a great case and a great outcome.
Perfect. Thank you very much. Any question or any comment, please let me know, and hope to see you next week. Thank you very much.
Thanks, everyone.
Thank you. Bye-bye.